Good evening to you all. Welcome to the 28th live webinar, Journal Club and Journal Scan of the Image. And we have a very interesting topic. Agenda remains same, it has not changed. There will be introduction to the subject by the moderator, couple of minutes, and then the presentations. Today's topic is about the redefining plasma cell leukemia. The bar is being raised, so there will be a topic discussed and followed by discussion, which will be led by Professor Prashant Emre from ACTREC, and presentation will be Dr. Sweta Rajpal from ACTREC as well. And it will followed by our Eagle Eye, who is results declaration, then about the next topic, and then there'll be a quick quiz for 10 minutes, and finally we'll sum it up. And about today's topic, there'll be presentations. Plasma cell leukemia, for a long time we knew that still is a very aggressive disease, whether it should be a separate entity or it should be called an aggressive myeloma. Now that we have better techniques, with better techniques we can define better, so that how much of plasma cells in the peripheral blood by flow or by morphology we can detect. And that's the topic today. So I invite today's presenter, Dr. Sweta Rajpal, to present the journal. It's about 2-year-old topic, but it still remains very important for all of us. Sweta, are you ready with your slides?
Yes, sir. I'm just sharing my screen. I hope my screen is visible.
It is. And of course, the quiz master is Dr. Nitin Yashash from Manipal Hospital, Bangalore.
So good evening, everyone. At the outset, I would like to thank the Image group Image group as well as Prashant sir, who asked me to present this article entitled "More than 2% circulating plasma cells defines plasma cell leukemia like multiple myeloma." This was published in Journal of Clinical Oncology in the year 2023, and this is a multicentric study where authors are from Czech Republic as well as from centers in the Spain, Poland, and Boston. So multiple myeloma, as we all know, is the second most common hematological malignancy characterized by expansion and accumulation of clonal plasma cell in bone marrow. However, tumor plasma cells are able to egress from bone marrow to peripheral blood, where they are responsible for dissemination and extramedullary disease. And circulating tumor plasma cells are detected in majority of patients of newly diagnosed multiple myeloma. So, is plasma cell leukemia just a spectrum of this disease or a different entity? So, plasma cell leukemia is an aggressive form of plasma cell neoplasm, which was first defined in the year 1974 by Dr. Robert Kyle. And this was a report of 17 cases who behaved very aggressively. And with this article, the definition of plasma cell leukemia was based, and it was more than 20% plasma cell in peripheral blood and an absolute count of plasma cell up to 2000. So this plasma cell leukemia definition remained so for a long time. And in the year 2017, an article was published in Hematologica where what was defined is that even patients having 5 to 20% of circulating plasma cell have worse overall survival as compared to that having less than 5% circulating plasma cell. A similar study that was published by the Mayo Clinic group, where they defined that instead of plasma cell leukemia being characterized by more than 20% plasma cell, similar outcome was seen in patient group of 5 to 19% circulating plasma cell, which was median overall survival of 1 year in between both the groups of 5 to 19% plasma cell and more than 20% plasma cell. So initially, when they saw the survival probability, what they saw in the overall survival, they could see difference between less than 5% plasma cell versus the 5 to 19, greater than 20 and 5 to 19% group. So what they did was they clubbed this both together into more than 5% and less than 5%, and they saw a difference in the outcome. So based on these both Spanish and Mayo Clinic study, the International Myeloma Working Group redefined plasma cell leukemia criteria into more than 5% circulating plasma cell. And this was taken into account by the 5th edition of WHO classification. And in current WHO classification also, the plasma cell leukemia is being defined as more than 5% circulating plasma cells. Now, apart from it being detected by morphology, where we have different studies, like this is an Italian group which looked into circulating plasma cell by immunophenotyping, and they identified a cutoff of 0.07%, and they could identify difference in the progression-free as well as overall survival, which was statistically significant in between the group that was having more than 0.07%, that is CTC high, versus low group, similar for both for progression-free and overall survival. And similarly, this is from the Spanish group, Dr. Bruno Paiva being one of the authors, where they identified a cutoff of 0.01% circulating plasma cell having a poorer progression-free survival as compared to more than 0.01%. So based on these articles, the objective of the current study was to assess the prognostic significance of circulating tumor cell in cases of multiple myeloma and identify a clinically relevant cutoff for identifying ultra high risk multiple myeloma, and also challenge the threshold of 5%, which was not actually based on any specific cutoff or any scientific basis. So here they have different cohorts. So discovery cohort, validation cohort, and a comparison cohort. Discovery cohort comprised of total 590 newly diagnosed multiple myeloma, and these were from 2 Czech Republic hematological centers. Among them, transplant eligible were 185 and transplant ineligible were 405, and they used a validation cohort of GEM-Claridex study or clinical trial, where they have taken 286 transplant ineligible patient, and they have compared with the comparison cohort that comprises of a published data of a retrospective data of multicentric study that had 95 patients of plasma cell leukemia, among which 40 were transplant eligible and 55 were transplant ineligible. In the baseline characteristic, this table lists the baseline characteristic. We can see that there's almost equal distribution in the ISS stage 1, 2, 3 in the transplant eligible group, while in the transplant ineligible group, more like 42% patients are actually stage 3. And most of the patients receive proteasome inhibitor-based therapy, 57.8% in the transplant eligible group and 77.2% in the transplant ineligible group. 42% of the patient received immunomodulatory drug also in the transplant eligible group. So peripheral blood sample was collected and processed within 24 hours. And depending on the year when the sample were processed, the panel differed, and it was 8-color antibody panel that was used. And the technique that was used was stain, lyse, and wash. Data acquisition was performed in BD-FACS Canto 2, and final analysis was performed in Infinicit software For enumeration of circulating tumor cell, it was expressed as percentage from total peripheral blood leukocytes. The median number of analyzed events were 3,41,918 and median limit of detection was 0.006%. Simultaneous bone marrow sample was of a particular patient was also analyzed, processed to confirm the clonality of aberrant plasma cells. For morphological assessment of peripheral blood, right GIMSA stained peripheral blood was used for circulating plasma cell, and two expert hematopathologists reviewed the slides, and minimum of 200 nucleated cells were counted. Appropriate statistical analysis was put. And if we look at results, circulating tumor cell was detected in 75% of the transplant ineligible cohort, and the limit of detection was 0.006. The median level of circulating tumor cell was 0.02% in transplant eligible group and 0.03% in transplant ineligible group. To define cutoff for identification of ultra-risk plasma cell leukemia like myeloma, what they did was they from the cohort from published literature, they took the median overall survival of plasma cell leukemia cases, and what they found was it was between 12 to 14 months. So they have taken plasma cell leukemia, they have taken 13 as a cutoff, and they have taken median OS of patients who are having similar 13 months overall survival, and they have taken median circulating tumor cell of those patients in the current study, and what they found the cutoff as 2%. So what they claim is that they are using a scientific basis to identify this as cutoff, and whereas previous studies where they had identified 5% as cutoff, there was no scientific basis of how they had identified that 5% as cutoff. So when they looked at this cohort of patient with 2 to 20% circulating plasma cell, it was comprising of 4% of total newly diagnosed multiple myeloma, with median percentage of circulating tumor cell in this group being 4.9% as compared to 0.03% with less than 2% circulating tumor plasma cell group. When they used this cutoff of 2%, what they found was in the survival outcome of a transplant ineligible patient, there was significant difference in progression-free survival, where less than 2% circulating plasma cell had 15.6 months of progression-free survival as compared to 3.1% in the more than 2% circulating tumor cell group. Similar was observed for overall survival, where the overall survival in the less than 2% group was 33.6% as compared to 14.6% in the more than 2% circulating tumor cell group. Now this same thing, now what they also saw that these 15 cases that were falling in this category of 2 to 20% circulating plasma cell, only 3 of these patients, that is 20% of the 15 cases, they showed a partial response, and rest experience either stable or progressive disease, indicating that this is a aggressive kind of category. First they saw in the transplant ineligible group, then same thing they saw in the transplant eligible group, where they found similar outcomes. I mean, of course, longer progression free and overall survival, but there was difference in the less than 2% and more than 2% group, where 25.3 months was median progression free survival for less than 2% group, and 15.4 months for more than 2% circulating tumor cell group. Similarly, overall survival for less than 2% group, the median overall survival was around 79.7 months, and that for more than 2% group was 43.1 months. When they compared the basic clinical characteristic and level of circulating tumor cell, what they found was the group of 2 to 20% had higher ISS stage 3, that is 73.3%, compared to less than 2% group, that was 41.2%, and it was statistically significant. They had elevated LDH, more than 2% had 53.3% of the cases had elevated LDH as compared to 9.8% in less than 2% group, and they had lower baseline hemoglobin and worse renal function. So in this figure, what we can see is the cutoff of 2 to 20%, we can see that more red or ISS stage 3, more number of cases are ISS stage 3. Similarly, more number of cases had higher level of LDH in 2 to 20% group. But however, this did not correlate with cytogenetics risk as well as median level of M protein. Median level of M protein was similar in both less than 2% and more than 2% groups. When they did a multivariate analysis, what they found was circulating tumor cell had independent association with both with progression-free survival as well as overall survival, apart from ISS stage as well and LDH. They performed this validation by using this 2% cutoff in an independent cohort of patients enrolled in GEM-Claridex trial, where they found similar findings of progression-free survival of median of 29 months in less than 2% group and of 11 months in more than 2% group. And similarly, overall survival median was not reached, but we could see a separation in the graph, though median was not reached and p-value was not significant. When they also performed analysis with reported literature. So this is a retrospective data that I had shown of around 95 cases of primary plasma cell leukemia. So this teal line is from primary plasma cell leukemia. So what they saw that the patients that were having more than 2% plasma cell, they were having similar outcome as in the median survival for more than 2% circulating tumor cell. Overall survival was 14.6 months compared to 13 months in the transplant ineligible group, and in the transplant in eligible group, it was 43.1 and 35.1. And both of this, when they compared, it was the difference between these two, that is primary plasma cell leukemia and the high risk multiple myeloma with more than 2% plasma cell in the circulation. They did not have significant difference between their survival, both in the transplant ineligible as well as eligible groups. So they wanted to challenge the 5% cutoff that was being defined for plasma cell leukemia. And because even when we are using a cutoff of 2 to 5%, the progression-free survival, and as we saw in the previous slide, the overall survival was also not different between the primary plasma cell leukemia and the 2 to 5% plasma cell as compared to the less than 2%. So they did a comparison between flow cytometry and morphology for quantification for circulating tumor cells, and they found a good correlation, especially in the lower level of plasma cell. They found a good correlation with a little distribution, with morphology showing a little more number of plasma cell. This red line indicates a median difference or mean difference between the two methods, that is 0.12, and it tilted more towards morphology. The morphology was enumerating more number of plasma cell as compared to flow. But there was the difference between the two was high. I mean, the limit of agreement ranged from minus 2.24 to plus 1.89. So these dashed line are indicating the limits of agreement. So what they, because of this discordance, they also came to a conclusion that more accurate result can be obtained from flow cytometry because it is more robust method. So if you look at primary plasma cell leukemia, it is an aggressive monoclonal gammopathy formerly characterized by more than 20% circulating plasma cell until 2021, where the threshold was lowered to 5%. However, in this study, the authors, they hypothesized that primary plasma cell leukemia is not a separate clinical entity, but a clinical spectrum of multiple myeloma with ultra high risk and a threshold of 2% of circulating tumor cell can help to identify this ultra high risk myeloma with practically identical prognosis as seen with primary plasma cell leukemia. And what they say is that, they want to keep it as ultra high risk myeloma because if they label patients as primary plasma cell leukemia, they are almost always excluded from commercial as well as academic clinical trial. However, paradoxically, these are the patients which need the most modern and intensive therapy. So that is why they want to say that it should be a spectrum of this and we should label it as ultra high risk myeloma rather than calling it as plasma cell leukemia as a separate entity. So circulating tumor cell has emerged as an independent prognostic factor for both progression-free as well as overall survival on multivariate analysis. And this is the first study that has looked at prognostic value of circulating tumor cell in transplant ineligible patient. Previous studies have looked at transplant eligible patient, but this study has proven it in transplant ineligible patients also. So in the present studies, authors were able to perform quantification of circulating tumor cell by flow cytometry and in addition to traditional morphology. So for all the solid cancers and blood cancers, prognostic risk stratification becomes very, very important, and identification of exceptionally favorable prognosis and ultra high risk disease is very important as it guides overall management of these patients. Now, in the evolution of this staging system, where initially international staging system from ISS to revised ISS to second revision of ISS, there is addition of cytogenetics to the criteria. But is it now time to add circulating tumor cell to the prognostic system is the question. So, circulating tumor cell, it can serve as reliable biomarker in 100% of cases as compared to cytogenetics, which is available only in 35 to 50% of cases in real world setting. And authors also propose that circulating tumor cell by flow cytometry can become standard part of diagnostic workup because it is widely available, highly sensitive, technically simple, and financially affordable method. To summarize, what they saw is that primary plasma cell leukemia, which was initially characterized by more than 20% plasma cell, then the threshold shifted to more than equal to 5%. But should we identify a lower number of circulating tumor cell, which will identify ultra high risk multiple myeloma with similar prognosis? They did identify patients with more than equal to 2% circulating tumor cell to have significantly inferior progression-free and overall survival as compared to less than 2% circulating plasma cell. And they devised a scientific rationale to get this threshold. So this is what they have emphasized in this paper. And they want to say that using this cutoff, they can identify, or we can identify ultra high risk multiple myeloma, which have features similar to primary plasma cell leukemia and will require more intensive treatment and maintenance regimes. So, however, in this, when we are going into flow cytometry techniques, where the worldwide, what we are seeing is that the circulating tumor cell can be detected at very low levels also, and the usual cutoff of current this thing is like detecting up to 0.01% also, and that is defining the separation between the progression-free survival and overall survival in a study. So this is study published from our lab itself, and there I had already shown two studies that have been published with 0.07% cutoff and 0.01% cutoff that are showing a difference between outcome of these patients. So in this study, they have not separately looked at lower level of cutoff separately for using flow cytometry. Maybe possibly it could be because of limited number of antibodies with older panel, because it is a retrospective study taking patients up to 2019 only. So that is one limitation I could think of, that I would like to thank you, and thank you for your attention. And if there are any
Thank you.
questions, please.
Thank you. Thank you, Sweta. Very well presented, and that has shown very nicely. As a presenter, you have criticized, but any further criticism you have, you can say in a minute's time before it's open for discussion.
For criticism. So, no, I think I could think of this limitation or this criticism.
Okay, thank you. We'll know more about it. Now I request Dr. Prasant to take over and discussion for the next 15 minutes or so.
Thank you, sir.
Prasant, please.
Yeah, so am I audible?
Yes, sir.
Yes.
Thank you, sir, and thank you, Image, for this opportunity. And this is a very interesting article. So I will start with the discussion. Usually whenever we talk about circulating tumors, one question comes to mind: why this? What is the biology behind coming plasma cells into peripheral blood when the primary site of origin of disease is bone marrow? So there's a beautiful article, couple of articles from the Spanish group, which is published in Leukemia in 2020, and which showed that there are some cells, some clone of these cells, where they actually behave like a stem cell, and they are going into dormant phase. What happens? The expression of some adhesion molecules as well as integrin molecules or activation molecules, they are underexpressed. For example, CD11A. CD11C, CD49DR, they are underexpressed. Adhesion molecules like CD56, CD138 are underexpressed. Activation molecules like CD38, 28 are underexpressed. At the same time, the marker which represents or which is overexpressed in stem cells like CD40 is overexpressed. So they look at what is the reason behind it, why there are this expression pattern, and at the same time they look at the genomics of these cells as compared to the bone marrow cells, and they have found that there are markers, gene associated with hypoxia are overexpressed, and at the same time, the gene associated with pro-inflammatory genes are overexpressed, indicating that if the bone marrow has more inflammatory condition as well as hypoxia, these cells, some of the cells undergo dormancy and do not proliferate. And how they confirm that? The genes which are associated with cell cycle and cell division, they are also underexpressed in these cells. So which indicates that the cells which has under inflammation or with the milieu of inflammatory milieu of bone marrow, they undergo and hypoxia, they undergo dormancy and they cannot proliferate. Now to form a microenvironment, bone marrow microenvironments which allow them to proliferate, these cells come to the circulation and then they move to the other side where they will find the appropriate environment which will not inflammatory and which do not suffer from the hypoxia, providing them more appropriate environment to proliferate. And this is the reason why some of the cells undergoes this one, which indicates that these cells have stem cell-like properties, and probably because they are under dormancy, they are not dividing, they are resistant to the giving chemotherapy. And that is the logic. Possibly these cases, the patient who has higher number of circulating plasma cells are associated with the poor outcome because they are not responding to given chemotherapy. So that is one biology which is behind the circulating tumor cell. Now, the main aim of this article, when we look at this article, the perspective is that whether plasma cell leukemia is a different disease or it's a spectrum of multiple myeloma plasma cell neoplasm, which has higher number of cells or the cells which are resistant and has been affected because of microenvironment, and that's why they're pushed to the peripheral blood more in number, representing the very aggressive disease, right? So previously, because we know that the 20% taking as a cutoff is 20%, we have defined plasma cell leukemia because morphologically it was easy at that time point. Now we have advanced technique where we can look at this plasma cell even at a lower level with more objective way, so that even the microscopy based bias can be avoided, like the technique like flow cytometry, where you can actually quantitate the plasma cell in the peripheral blood to its precise level. And then you can and also provide the reproducibility to that. So on morphologically, when you have more than 5% or more than 20%, it is more reproducible. But when you go below that, it is not reproducible. And that's why I think for a few years, the definition was not revisited. But when we look at the IMWG's 2019-2021 guidelines, they were reduced based on the two studies from Spanish as well as Mayo Clinic study, where they looked at the patients where even less than 20% plasma cells are behaving same way. But then they thought what should be the cutoff, and then again morphologically the comfortable cutoff, reproducible cutoff, they can be reduced up to 5%. So they consider as a 5% fitness cutoff and shown that the outcome is similar to that of more than 20%. But the author of this paper is they come to they discuss and they argued that this 5% based on the it's not still the scientifically used cutoff. Now, in this paper, they looked at more than 300, 400 patients where they wanted to look at so they wanted to look at whether this cutoff is a real cutoff or can it go even lesser than that based on the scientific data or scientific method like statistical methods. And they have taken the published data with plasma cell leukemia, and they found out that the same concept of taking the same median overall survival. My computer is giving some trouble. So overall survival, and based on that, considering that overall survival, they looked at if we take that median overall survival of published plasma cell leukemia, and if you do a local local linear regression, and to see which level is exactly matched with median level published plasma cell, they have put the cutoff of 2%, and then they looked at based on that cutoff outcome. So and they also look for they also validated with the prospective cohort or the cohort from the other study, which was prospectively enrolled, and showed a similar difference or similar outcome with cases with 2 to 5% of cutoff, or more than 5% of cutoff, or more than 20% of cutoff. And then concluded that the patients who had more than 2% circulating plasma cells has similar outcome to that of more than 5%, which is current definition, or which is similar to that of more than 20%. So why instead of putting the cutoff for the plasma cell leukemia at 5%, can we go down? But at the same time, their argument was that they don't want to change the definition of plasma cell leukemia, but they want to highlight this data or the circulating tumor cell as an independent prognostic marker for ultra high risk disease, which behave like a plasma cell leukemia, or we can say which behave like the extreme end of adverse group of multiple myeloma, which we define as a plasma cell leukemia, but it is just multiple myeloma with higher number of circulating tumor cells. At the same time, they have shown that M protein level doesn't make difference, or the cytogenetics, even high-risk cytogenetics doesn't make difference between these two group of patients, indicating that these are the high-risk patients, and possibly does not represent the disease burden, because the M protein level is same between the two groups, that which indicates, which also reflects the disease burden, probably is not that's why the circulating tumor cell probably does not represent the disease burden, but it is a part of tumor cell which are overall adapted or modified their genomic or the biology in such a way that they are resistant to the given treatment and possibly are eligible for more intense therapeutic intervention to improve their outcome. So that was it. Then I would like also highlight the laboratory part. If you look at the laboratory part now, plasma flow cytometry has become standard of care. Especially since the MRD has come, even though diagnostic, not many patients are required flow cytometry. But for MRD monitoring, it has become the gold standard by using flow cytometry. And acquiring 1 million cell is not difficult nowadays. Here, if you look at the cutoff, 2% means even 1 lakh events or 2 lakh events acquiring is enough to go for such a level detection. In fact, when you look at overall survival, not only just aggressive disease, but overall outcome, poor risk multiple myeloma patient, we have shown, as well as Spanish group has shown, that the cutoff of 0.01% of circulating tumor cells. For that, you need just 1 billion cells. The panel is same, simple 8 to 10 color panel, so it's not costly. It is highly reproducible because we are already using this cutoff for BLL, MRD, and other diseases. So it's not time consuming also, and it's a simple assay. So as far as the laboratory reproducibility is there, standardization is there, it is already standardized in many laboratories, many big institutes, and highly reproducible also. So on that front, it is already standardized. As far as morphology is concerned, if you have shown there, the Bland-Altman analysis, they have shown that when it comes to the low level, it is still matching, but when it comes to high level, there is high variation, because morphologically, sometimes plasma cells can look like activated lymphocyte, or activated lymphocyte can look like plasma cells, and with inexperienced eyes, there can be confusion because we are just counting 200 cells, and 200 cells, one cell in 200 will be like, 5%, which is not right reproducibility or right way to do it. Either you count 1,000 or 2,000 cells, which is practically not possible. And that's why author has argued that, using flow cytometry, which is cost effective, highly reproducible, standardized technique, is a better way for looking at circulating tumor cells. At the same time, we have seen now almost 6 to 8 studies which at different setting, ineligible, transplant ineligible, transplant eligible patients with different kind of treatment, that circulating tumor cells independent of high-risk cytogenetics, independent of other risk factors, and easily doable. So should be a part of ISS staging system, revised ISS staging system for the prognostication. I think that was the last argument what they have studied. So I think
Thank you, Prashant. Uday has a question or comment. Uday.
Yes, sir. Thanks a lot, sir. So firstly, I would like to compliment both Shweta as well as Dr. Prashant for elaborating on the nitty-gritties of this particular article. I've got 2 comments and 1 query for Dr. Prashant. As far as the comments are concerned, these are primarily to Dr. Shweta, and for those who are interpreting the study. First of all, though the authors might have said that they have evaluated it in a very statistical way, the answer is no. The reason being, when we require any cutoffs to be taken, we need to take Yoden's index. So that exactly gives us the right cutoff what to be done. That's why you yourself have shown that some people have taken cutoff of 0.07%. Some people have taken cutoff of different cutoffs. So today I decide that I want to take a cutoff of 1.5%, and I use the same data sets retrospectively. I'll still have widely separated curves to show more than 1.5 and less than 1.5 having survival difference. So where, to what level should we actually go to? So that depends on Yoden's index, and these people have not done that. So they have taken an arbitrary cutoff based on author's opinion of what cutoff to be taken. So that was not scientifically drawn cutoff. They have tried to prove the cutoff scientifically by giving various graphs and curves. Okay, so that's the first difference. Now, second point, when you showed the graph of morphologically, in fact, there was a difference of 0.12% better in morphology when compared to flow cytometry. So all of us would immediately, it will click in our mind, how can this be possible? So when we talk of morphology from all the Western data, when we take the data from European Union and in US, morphology does not mean like in India where people are actually doing a 200 cell count with a cell counter. That's what most of us do it. These are all automatic slide stainers and automatic cell sorters which are there, and they pick up their plasma cells from this. So their morphology and our morphology cannot be put next to each other. So when we interpret it for our scenario, Indian scenario, or in low and middle income countries, so the percentages that we or our pathologists pick up on a 200 or a 500 cell count might not be. I cannot say that you and Dr. Prashant are the experts on this, but might not be same or at a par with the flow cytometry. So for all the studies that you people are doing and trying to propagate, I feel what Dr. Prashant say, I will reiterate that flow cytometry has nowadays become a test which is so easily available, and with the effect of your societies of flow cytometry, you are trying to standardize it across the country. We should not even put it into the mind of the people that morphology can be at par for such low levels with flow cytometry at the in the initial diagnostic scenario. So these were my comments. As far as my query is concerned,
Can I
yeah, Shweta, go ahead.
Basically, in the methodology for morphology, they have mentioned that 200 cells were counted by two separate independent hematologists without both. So that way, it sounds like they have not, in the methodology, they have mentioned that they have done a manual counting and two hematologists have counted 200 cells. So I
So
don't.
Shweta, so how it takes place is, even like, because I have been in some few of these labs.
Right.
So what happens is, at the end of it, when the computer gives you that these are the total number of plasma cells on an automated counting, the hematologist picks up actually that how many does he want to include into his, considering it like the way the Dr. Prashant was saying. Many of them can be confused with activated
Correct.
lymphocytes and others. So the hematologist finally picks up that, okay, the computer has given so many numbers. How many numbers should I finally agree to or not agree to? But it is definitely not a manual counting that most of us do, sitting on the lab side, middle of the night, burning our midnight oils. So that's not the way that's done there. So anyway, so that separate. Now I have a query for Dr. Prashant. So Dr. Prashant, you people have been really trying to propagate this flow cytometry for peripheral blood, and both for MRD purposes and also for diagnostic purposes. So, and also for the diagnostic purposes. Now the two questions which I have is, now many of us do not have the liberty or all the facility of having intra-institutional evaluation or these flow cytometry techniques. So sample is transported to an outsourced lab. So what would be the pre-analytical variables which will modify the circulating plasma cells? Number one. Number two, do we have any way of overcoming this problem? And number three, when these people report to us at baseline, so what would be the minimal panel that you will advise? Because see, MRD is a different scenario where you can have various aberrances. But this particular topic today is that newly diagnosed multiple myeloma, using it as a different prognostic marker. So what can be the minimal panel which can be used for this purpose?
So,
I request Prasanth to be a little bit crisp because we have to stick to the time. Thank you.
So, Uday, thank you. Yeah. So, let me answer your question that, the first is when it comes to if you want to transport the sample, we know the plasma cell, CD138 is, highly labile antigen. So, we prefer the sample which is sent in EDTA sample, but we prefer it is sent to be between 18 to 20 degrees Celsius, not too cold, not too warm. If too cold, like 7 to 8 degree exposure can cause the reduction of CD138. However, that does not limit as long as we have one additional marker for the gating, even independent of CD138 can be done. That is one thing. Usually, because usually at the time of diagnosis of the patient may have around, counts are normal, like 5,000, 6,000. So even, if you have 2 ml of blood sample, that sample is enough to acquire 1 million cells, which give you good confidence to go even up to 0.01% of identifying abnormal plasma cell. Second thing, the minimal panel. So minimal panel, see, what we have seen is that usually you need two gating markers in addition to CD45. So CD138, 38, and 45, these markers are necessary markers. And at the same time, the commonest aberrant marker which is expressed, even these abnormal plasma cells, are CD56 and loss of 19. So you have to have CD19 and 56. So you add 2 more markers. That will be like 5 markers. And we need to confirm the light chain expression kappa and lambda. So that would be 7 markers. So you have to have at least 8 color panel, which is available in almost all clinical labs in India. 8 color panel, and you have to put 8 markers. So the 8 markers will cost around 2,000 rupees if in-house antibody, or maybe in some referral lab it will go up to probably 3,000-4,000 rupees. I don't know how the outside lab, how much outside lab cost or charge for the patient. But usually the 8 color marker single tube will suffice to identify diagnostic circulating tumor cell. That is the answer to your second question. Now, just coming to that part, the cutoff level. If you look at the Yoden index, that is by using ROC. Now, the reason I'm discussing is why they have not used that. The problem is with Yoden index, if you look at, they have tried cuboidal spline method, but it was not working because the reason is when you take a cutoff by using ROC, which says certain sensitivity specificity. For example, we take at age of 55 years cutoff for the poor prognosis. Now, what happens if it is the patient is 54 and what happens if the patient is 56? Not much different as compared to 75-year-old. So that the ROC method or index, Yoden index method has this limitation. What they wanted to look at, they wanted to look at a particular group of high-risk patient, the patient which has median survival equivalent to published plasma cell leukemia with more than 20%, which is around 13 months. So they wanted to look at that set of patient where they match with the what kind of circulating tumor cells will give equivalent overall survival. And that's why they have done the linear regression with the local regression method, which is called losses method, where you take the median number of patients with median 13 months survival and see what was the count based on the linear regression, what was the best median cutoff matches with that. And that's why they have put the cutoff. Otherwise, you will have something around 0.0 because it will separate. But it will not give you a specific group of less than 1 month or 13 months high risk. So that is why they adopted this statistical method. That was the explanation for that adopting this statistical.
Thank you. Thank you, Sweta. Thank you, Prasan. Very beautifully presented. This was a very important article from the basic science point of view, even from the clinical point of view. And then thank you, Uday, for asking that questions. There would have been more questions, but we need to move on in the interest of time. And next comes up in the agenda is our Eagle Eye. Uday does it or Sumit will do that?
Sir, there is one question from Komal from MICE, I think, in question part.
Okay.
Yeah. So I'll just, it's a question is, what is the genomic landscape and these of these and 2% cover which you elucidate to where the outcome and hypox. Okay, so if you look at the genomic expression, so just answer because you can go, because there is limited time, you can look at the 2020 leukemia paper with detail. They have done all transcriptomic and everything with genomic. But as far as the disease, pathogenic mutations, as well as copy number analysis is concerned, the incidence was not too different. And that's why they look for the hypoxic genes as well as, the genes, pro-inflammatory genes or the cell cycle genes, indicating why, although the cytogenetic is same, why even the mutation profile is same, copy number analysis is same, why there is these cells are coming to circulation from the bone marrow, and that they try to explain based on these biological features, basically.
True. Thank you. So,
shall I go ahead?
Yeah, Sumit, please.
Okay. So are my slides visible and am I audible? Neerav, am I audible and my slides are visible?
Yes, your slides are visible and you're audible.
Okay, thank you. Thank you, Sweta and Prashant sir, for the excellent journal club presentation and discussion. So coming to the Eagle Eye competition for this month, the journal scan article was definition and clinical significance of MGUS-like phenotype in patients with monoclonal gammopathies, published again by the Fatima group in 2023 in JCO. So just to give an overview of the process for patients, for people who are new to this, a recently published article is chosen. We invite a commentary of 175 words or lesser before a deadline. Anybody, irrespective of designation, can send their respective commentaries within the deadline period, and whosoever wins presents a journal scan, gets a certificate with credit hours and image lifetime membership. So the purpose is to read the latest articles of plasma cell dysplasias, refine the art of critical appraisal and art of scanning an article, more letter to editors from our country, and get an opportunity to present in front of a good national and international audience, which will further foster inter-institutional competition. So the variables on which they are analyzed are summary, title, the abstract representation, some assumptions, critical word count, which is very important, some authors' interpretations, which may be overemphasized and underemphasized, the approaches, the statistical methods, the references, and finally boiling down to a final score. The important points are that those who are sending the commentary should stick to the word limit, be succinct, and still convey a critical analysis, and do concentrate on the methodology and statistics. Before analyzing announcing the name of the winner, it is important to thank the reviewers, Dr. Kunal Sehgal from Mumbai, Dr. Prashant Sharma from PJ Chandigarh, and Dr. Jasmita Das Man from AIIMS New Delhi. So before name of the winner is announced, a special mention for Dr. Pratishtha Madan, who is senior resident in hematopathology at ACPEC, Mumbai. So there was a tie between herself and the winner, and the third reviewer, Dr. Jasmita Das Madam, actually resolved the tie, and she lost few points because she sent her commentary 17 minutes beyond the deadline. The deadline was 16th of Jan, 23:59 hours, and she sent it on 17th of Jan at 12:17 a.m. That was one of the few negative marks for her, apart from what she got. And special mention for Dr. Naseem Mumtaz from across the border, from Lahore General Hospital, Lahore, and this is the first time we've got a commentary from outside India. So the winner of this month is Dr. Anupam Brahma from TMC Kolkata. He's a fellow who's working in the Department of Clinical Hematology and Cellular Therapies at TMC Kolkata. So congratulations, Dr. Anupam Brahma, and I would hereby request Team MyStudies to display the recorded version.
Good afternoon,
Thank you,
everyone.
Sumit.
Thank you for giving me this opportunity. I am going to discuss this article, Definition and Clinical Significance of MGUS-like Phenotype in Patients with Monoclonal Gammopathies. This article came up in Journal of Clinical Oncology in March 2023. So let us first discuss the concept of the MGUS-like phenotype. So as we know, in smoldering myeloma, the rate of disease progression to active myeloma in the first 5 years is 10% per year. So the high risk population who are at high risk of disease progression has been a research priority because this group of patients are therapeutically targetable. Multiple models like IMWG 2220 criteria or some other models has been formulated to identify this high risk population. Conversely, there should be a subset of patients who are at minimal risk of disease progression. Question is how to identify this group. Similarly, we all get some patients of multiple myeloma who remain M protein positive, which means VGPR or less than VGPR response after the induction therapy or transplant. Some patients among them may not require additional therapy for survival benefit. From here, the concept of MGUS-like phenotype came. In monoclonal gammopathies, conceptually, these subset of patients show extremely benign clinical course. So the question is how to identify this subset of benign patients at baseline. Earlier, people tried gene expression profiling and flow cytometric based methods to identify this group. In the current study, the authors describe a novel flow cytometric based method to identify this benign group. The method is based on frequency of total plasma cell and percentage of clonal plasma cells within the bone marrow plasma cell compartment. The identification of bone marrow plasma cells was done by CD38 and CD138 bright expression, and the monoclonality was identified by under expression of CD19, 27, 45 and 81, and along with that over expression of CD20, CD28, 33, 56 and CD117. Then this mathematical formula was used to develop the logistic regression model, and based on the probability outcomes, patients were classified as MGUS-like, intermediate or MM-like phenotype. Then this was validated in a large cohort of 3000 patients. Good news for us is the calculator is available online, where we just need to put up percentage of total plasma cells in marrow and percentage of monoclonal plasma cells to know the risk type in any given patient. This was the study design. First, the calculator was designed using 548 MGUS and 2000 newly diagnosed multiple myeloma patients, and then it was validated using about 3000 myeloma, smoldering myeloma and AL amyloid patients. Now let's see about the validation results. In Spain, 18% of newly diagnosed smoldering myeloma patients were classified as MGUS-like. In USA, it was 19%. In Spain, after a median follow-up of 2.5 years, the estimated rate of disease progression at 2 years was only 4.5% in the MGUS group, whereas the rate was 28 and 62% in the intermediate and multiple myeloma-like group. Similar results were found in USA also. If we look at the time to progression in smoldering myeloma, it was very long in MGUS-like group, whereas shorter time was there seen in the other two groups. Now, it was seen that the patients of smoldering myeloma who are at high risk of progression by IMWG 2220 model, 3.5% of this high risk group show MGUS-like phenotype. Now, to treat or not to treat in this 3.5% of people. So the high risk patients were treated as per PETHEMA or CESAR trials, and the disease progression rate was 0 at 5 years. The MGUS-like cohort was observed only, and the rate of progression was 6% at 5 years. But the p-value among these two groups was not significant. It indicates that even if the smoldering myeloma patients who are at high risk of disease progression by IMWG criteria, if they show MGUS-like phenotype, we can avoid treatment in them, and it does not increase risk of progression in these patients. Now, what are the study results in multiple myeloma? Data from Spain and Czech Republic show that the MGUS-like group has PFS and OS advantage over intermediate and multiple myeloma-like group. The PFS and OS rate of at 5 years in MGUS-like group was 79 and 96% only. By multivariate analysis, it was shown that MGUS-like phenotype is a separate prognostic factor along with ISS staging and cytogenetics. Another important discovery was that the MGUS-like cohort, even if they do not show complete remission or MRD negativity after induction treatment, the OS and PFS remain similar to those who show CR or MRD negativity. But this happens only after treatment. It does not mean that MGUS-like phenotype does not need treatment. In AL amyloidosis, the multiple myeloma-like phenotype show that this group has the most dismal PFS outcomes, and whereas the MGUS-like phenotype group has the most good median PFS value. Now, limitations of the study was there was no cytogenetic correlation, and we do not know what will happen in a individual patient who has both high risk cytogenetics by PCR or FISH and low risk MGUS-like phenotype by flow cytometric method. So in conclusion, we can say that MGUS-like classifier identifies a subgroup of patients in smoldering myeloma and active myeloma which has favorable outcomes. In smoldering myeloma, it promotes personalized therapy approach to overcome overtreatment, and in active myeloma, it shows that patients with favorable biology benefits the most from the intensive therapy. But on the contrary, this study fails to show that treatment may be stopped in patients with favorable biology. This study opens scope for future models. There may be a combined flow cytometry and cytogenetics based model to better identify the MGUS-like phenotype, which is a benign group. With this, I thank you all for the patient hearing, and thank you again for giving me this opportunity. Thank you.
Thank you, Dr. Anupam, for your nice presentation. Neerav, can you allow me to share my screen again? Okay. This was a regulatory commentary Now coming to the Journal Club article for the next month, which is due on 27th February 2025. The theme for that is smoldering myeloma. And the Journal Club article will be daratumumab or active monitoring for high-risk smoldering multiple myeloma, published last month in NEJM. And this is one article, and this field is one field which has generated a lot of discussion and controversies also. A journal scan article for Eagle Eye competition for the next month, 27th February 2025, is a recent article published in Blood Cancer Journal, which tells us the mode of progression in smoldering multiple myeloma, a study of 406 patients from the Mayo Clinic group. I'll just keep this slide on for a few seconds. Thank you. And over to Dr. Nitin Yashas for the quiz.
A very warm good evening to everyone. Once again, gratitude and thanks to the image organizers for giving me an opportunity to conduct the quiz again. Very, very interesting articles, and it was very fascinating to listen. And of course, the journal scan, which almost integrates what is possibly a lower level of deep learning or machine learning, so to speak, the basic form of it to try to look at, can we predict a different phenotype as such? Next slide. So as always, there is going to be, next slide please, there's going to be 5 questions, one on history and trivia, 2 on the Journal Club article, and 2 on the journal scan. Can we have the next slide please? Yeah, so 5 questions, 30 seconds for each question. And remember, you have to be fast and accurate, because if there is a tie with the number of questions each person has got correct, the one who has answered fastest is going to win as such. The aim of this quiz is, apart from the competition part, is to see whether you have really got home the take-home messages, which has been wonderfully discussed by all the speakers, the panelists, and the guidance which has been given by our senior professors and teachers here. So if you're all ready, the first question to start off with, very, very simple question. Can I have the first question, please? Right. Who coined the term multiple myeloma? Who coined the term multiple myeloma? Was it Otto Kohler? Was it Samuel Solly? Was it Ron Ruzitsky? Or was it Henry Benz Jones? Who coined the term multiple myeloma? The history of myeloma, as we all know, goes back to almost the 1800s. Some very fascinating stories in there. But who was the first one to give the term multiple myeloma? All right, we move to question number 2. What was the median percentage of CTC plasma cells which was detected in the transplant ineligible newly diagnosed multiple myeloma? What was the median percentage of CTCs which were detected? Was it 1%? Was it 3%? Was it 0.01%? Or was it 0.03%? Very fascinating discussion, but we know that around in 75% of them CTCs and plasma cells were detected, but what was the median percentage detected? Right, moving to question number 3, read carefully, and this is the take-home slide of the Journal Club article. Which of the following statement is false? Remember, what is false with regard to prognosis? The timer can start. Was it the optimal cutoff of 2% to identify is applicable even in transplant eligible? 2 to 20% CTCs have the same OS as that of plasma cell leukemia. Patients with 2 to 5% CTCs had a better PFS as compared to 5 to 20% CTCs, or is it D, all the above statements are false? All right, we move to question 4, which is from the
journal Scan article, very fascinating. And again, this would be the take-home slide from that. And which of the following statements here is true with regard to the algorithm of a MGUS-like classifier? MGUS-like phenotype MM had a significantly better PFS. Timer can start. MGUS-like Smoldering MM had a higher rate of transformation. There was a significant difference in the time to progression in a MGUS-like Smoldering MM between those who received treatment versus those who were on observation. And lastly, the MGUS-like classifier did not complement the revised ISS scoring. Which of the following statements is true? Right, we come to the last question, and we know that they used clonal plasma cells and morphological evidence of plasma cells. Very wonderful explanation given by Dr. Uday on that also. But the clonal plasma cells was discriminated from normal plasma cell based on the underexpression of what? Timer can start. The timer can start. All right. Some of you attending, next slide, please. Some of you attending this quiz and looking at the questions, maybe feeling like this, thinking that all the options look exactly the same as other and who is the real Spider-Man. But again, with great power comes great responsibility. So goes the famous quote. So let's have a look at the answers. So the first answer was who coined the term multiple myeloma. Next slide. Was von Ruzitsky. He saw in multiple patients, multiple tumor-like growths in the bones, the erosion of the marrow happening, and that's why the term multiple myeloma came about. Moving to question number 2. Next slide. Right, so 75% of the patients in the study had a CTC detected, and the median percentage of CTC detected was only 0.03%. So it was only in a small fraction that the CTCs, and that is why the cutoff of 2% was arrived, because a large number of them had CTCs, which was 0.03%. Moving to question number 3. Right, so which of the following statement is false? So I think a lot of discussion has happened, but the one thing which always comes to us as a clinician mind is, would 5% be better as compared to 20%? And the answer is no, irrespective of whether it was 2 to 5% or whether it was 5 to 20%, all of them tended to have a bad PFS. There was no difference in the PFS with those who had 2 to 5% CTC plasma cells as compared to 5 to 20%, which is why 2% is really the cutoff to look at ultra high risk myeloma, which is almost behaving like a plasma cell. So option C was the correct answer. Moving to question number 4. Right, and this was a very interesting logistical regression and predictive sort of models which were built, and very clearly it was shown that the MGUS-like phenotype myeloma had a significantly better PFS. One of the easier questions of this quiz, there was actually a lower rate of transformation as expected. And again, interestingly, as the next Journal Club article for next month is going to talk about daratumumab, what was seen here was that those who had a MGUS-like Smoldering MM, there was no difference in the time to progression between those who received treatment versus observation, even if it was clinically a high-risk group based on traditional features. So very clearly, a phenotypic manifestation of a MGUS-like Smoldering MM, you don't need to treat, is what this study says. And the last question, a very basic hematopathological question on what was used in the study, and the answer was an underexpression of CD27, but an overexpression of all the other markers that you see here was used to discriminate a clonal plasma cell from a normal plasma cell. And that is the essence of the study in looking at the morphological plasma cells and the clonal plasma cells. So with that, we come to the end of this plasma cell-filled quiz. Hopefully our plasma is not boiling, and over to the organizers and Sumit for declaring the winners as always.
Neeraj, you can announce the name of the winner.
Sir, it is last time winner Bharanidharan M from Chennai.
Okay, great. Congratulations. Over to Tappan sir, a vote of thanks.
Okay. Thank you very much. We had a very fascinating evening. The field of multiple myeloma, especially treatment, certainly no question about that. But the basic science, I think, is opening up the field so very quickly because of the technologies that we have now, and the people are asking questions every day. And then today's article that was discussed was one of those. I think there are many questions. I think this article has opened up more questions than answers. And Prashant has touched upon that. Sweta presented very well. And then presentations on the journal scan was fantastic. Again, it raises many more questions. And the quiz, I love the quiz actually. The simple looks simple, but I suppose those who listen, the article carefully would have answered appropriately. Thank you very much, the organizers, the IMAGE, our president now, Dr. Velu Nair, past president, Dr. Pankaj, Uday, always, Sumit, the moderator, and Sweta, Prashant, Sumit, and finally Nitin and our colleagues from the Mice Ideas. Thank you very much. Have a good evening.
Thank you, sir. Wonderfully done. Thank you very much.
Thank you.
Thank you. Bye-bye. Thank you to Dr. Reena Nair also. She also joins.
Reena, yes, always.
Nice.
Thank you.
Thank you.
Thank you.
Thank you, Pankaj.
Thank you. Thank you, sir.
Thank you.